My name is Randy Hecht. I'm director of the GI Oncology program at UCLA, and I'm really lucky to have a wonderful group of people who just finished giving talks on solid tumors and cell therapy. Usually with cell therapy, obviously we're thinking about our colleagues who have been so successful in hematologic malignancies, but there's a lot of excitement and a lot of work that was done by actually the people here that really is bringing some of that excitement to solid tumors. And so I'm going to ask the rest of my panel to introduce themselves.
Yes, thank you. My name is Winfried Alsdorf from the University of Hamburg. I'm a hematologist and medical oncologist, and my special interest is cell therapies in solid tumors and early phase clinical trials.
My name is Susanne Baumeister. I'm a pediatric oncologist and the clinical director of the pediatric cell immunotherapy program at Dana-Farber Cancer Institute in Boston Children's Hospital.
And my name is Jennifer Specht. I'm a breast medical oncologist, and I practice at Fred Hutchinson Cancer Research Center at University of Washington. I'm a clinical research director for our breast oncology program, and have the privilege of working with our cellular immunotherapists as well.
So I think what we'll start is each of us just finished giving a discussion and a talk, and I think we'll talk a little bit about what each of us talked, and then I think one of the most talked about, and I think one of the most interesting things is sort of the interaction, because while hematologic malignancies are a relatively small space, but biologically as well as from the way people treat them, solid tumors are incredibly diverse, and while there are overlaps, and hopefully we can learn from each other, there are clearly differences. And so what I spoke about were logic-gated CAR-Ts for pancreatic cancer. Pancreatic cancer, as I mentioned, is the third most common cause of cancer death in the United States. It will soon be the second most common cause of cancer death. We do really poorly. Only about 20% of people are ever resected, and most of those end up dying of their disease. In people with metastatic disease, and patients who are well enough to go on a randomized phase 3 trial, median overall survival in our most recent phase 3 trial was still only about 11 months. Cell therapy has been particularly interesting, but the problem in solid tumors, and this is something that will be discussed because all of us deal with solid tumors, is that we don't have a wonderful target like CD19. Instead, the targets that we have either are found in relatively small numbers of patients with combinations of HLA and perhaps specific mutations that are presented, or more common tumor targets, tumor-associated antigens, but we worry about on-target, off-tumor toxicity. And just briefly, logic gating is a way perhaps to maintain efficacy but minimize on-target, off-tumor toxicity. Some of the trials that I discussed were together with my colleagues at A2Bio. They do have a logic-gated CAR-T, which is a not-and gate in patients who have A2, which is about 40% of North Americans. They've actually expanded it, so it's not just A201, but also A2, which makes it a more ethnically diverse population, still about 40%. And looking for a loss of that in the tumor, known as loss of heterozygosity. And actually, Dr. Specht also spoke about some of those studies as well. The ones in pancreatic cancer that we've looked at are Everest-1, which was CEA and did show a response in a patient with pancreatic ductal adenocarcinoma. And I have to say, cell therapy responses in pancreatic ductal adenocarcinoma are rare. And in fact, as I pointed out, one in 2022 led to a New England Journal article. But it's something that's very interesting. There are other targets from my standpoint that are interesting, but are also found in other tumors as well, such as mesothelin. One thing that we have been able to show has been actually excellent tolerability, and also with hints of activity. So with that, I'm going to just say that's a brief sort of discussion about what I presented. Dr. Alsdorf, do you want to talk about what you talked about?
Yeah, of course. So I'm involved in a phase 1 trial that is running now for several years, investigating a novel target, Claudin-6, and you talked about this issue with on-target of tumor toxicity, but the data we've obtained so far now show that really Claudin-6 is a really suitable target for cellular therapies because we do not see this issue. What we have seen in our trial involving Claudin-6 positive solid tumors is that we see frequent cytokine release syndrome, which is kind of surprising because the field actually thought that really CAR T cells have a difficult stand in solid tumors. They do not penetrate into the tumor. You do not see any inflammation or whatsoever, or even responses, but we have seen frequent CRS and frequent responses also. And notably, what is really interesting is in the rare disease setting of relapsed germ cell tumors, because germ cell tumors are very special, not just that they have a high cure rate with standard chemotherapy, but those few patients who are unfortunate to have refractory disease, these tend to be young patients who have a very dire prognosis. But these germ cell tumors have a special property. They are uniquely positive for Claudin-6. So really Claudin-6 seems to be a prime target for this specific population. So I focused in my talk on data on the germ cell tumors from this trial. And we've investigated the Claudin-6 CAR T cell therapy and also an innovative combination with an mRNA vaccine that is designed to boost the CAR T cell activity by coding for Claudin-6. And we've seen with both approaches, with the monotherapy and with the combination, that we see toxicity that is really comparable to the hematological space with CAR T cell therapy, but it's manageable. And I pointed out in several patient cases that we see durable responses in some patients, which is really promising and which is much better than what we have seen with previous attempts, which have been all futile in targeted therapy for germ cell tumors. So this really paves the way for our upcoming phase 2 trial, which will enroll in the US in 2025 and in 2026 in Europe. So this is really interesting, and maybe leading to my colleagues, I was really amazed that not just 1 or 2 trials, but in many trials we now see positive data, and we see that the field is moving forward. I was especially impressed with data from the local treatment of ovarian cancer from Winfried Cancer Center. This is really exciting time to use cell therapy in solid tumors. So I would now refer to my colleagues.
Dr. Baumeister?
Yeah, great. I had the opportunity to talk about a new CAR T cell approach for a pediatric tumor called neuroblastoma, which is the most common extracranial solid tumor in pediatric cancers and accounts for about 15% of pediatric cancer deaths. And about 50% of those patients have high-risk disease features, and their event-free survival long-term with the current treatment modalities, which are very intensive and fairly toxic for young patients, are still suboptimal on the order of 50%. And so this remains an important area of investigation to improve that field, and especially to have available therapies for patients who relapse or have refractory high-risk neuroblastoma, which is unfortunately about 50% of those with high-risk disease. And so we talked about a new approach targeting a novel antigen in neuroblastoma, which is the ALK receptor. In contrast to some of the ALK aberrations and ALK translocations that are common to some of the adult tumors, such as non-small cell lung cancer, which lead to an intracellular fusion and cannot be targeted by a CAR T approach. In neuroblastoma, the ALK receptor is expressed on the cell surface, and patients can have either aberrations or amplification of the ALK receptor expression or mutations of the ALK receptor, but the vast majority of patients express at least the wild-type regular ALK receptor on their surface, and so this appears to be a very good target. I showed some data that expression in healthy tissues, which is obviously important for toxicity, expected toxicity, is really absent, save for some scattered expression in enteric neurons. And so we expect that this hopefully should be very safe from a on-target off-tumor perspective. I also described that based on the preclinical models of this approach, which was developed by Dr. Roberto Chiarle at Boston Children's Hospital, we see very good preclinical ALK CAR T efficacy in murine models when the ALK expression on the cell surface is high. But I also showed that a clinically used ALK inhibitor called lorlatinib is able to actually increase the ALK expression, especially in ALK mutated patients, but also those with wild-type ALK receptor expression. And so suggesting that the combination of lorlatinib with the administration of ALK CAR T cells could be a very good combinatorial combinatorial therapy to be explored in the future. And so I had the opportunity to outline the first really in human phase 1/2 clinical trials targeting ALK, which will explore monotherapy of ALK CAR T cells initially, but with the hope to later introduce a combinatorial regimen with lorlatinib, and was able to share that this trial was recently activated and is now open for enrollment. And so we hope to be able to report early results from this trial soon.
Really interesting. Dr. Specht, would you like to discuss what you talked about?
Certainly. So I had a chance to give a little bit of a history. So one of the trials that I was privileged to be involved with at the Fred Hutch was a first-in-human study that looked at a cellular immunotherapy target called ROR1. And ROR1 is unique in that it is expressed primarily during embryonic development and is absent on most adult tissues. However, it also can be expressed at high levels both in hematologic malignancies as well as in solid tumors. So it offers a really unique window of opportunity to try to understand a little bit about how to reconcile the really tremendous success that we see for hematologic malignancies versus what has been much more slow and difficult efforts to make for solid tumors. And so this study was a relatively small study, but we were able by conducting a lot of correlative science work to see that some of the important things are very different among the patients with CLL, where we were able to see, generally speaking, brisk expansion and persistence of those ROR1 CAR T cells. However, the very same CAR T cells in patients who had non-small cell lung cancer and triple-negative breast cancer, there were only a handful of patients who had good evidence of CAR T cell expansion and persistence. And so we learned a number of lessons that have become reflected, I think, throughout multiple discussants that we're seeing as patterns of challenges that target what we do in solid tumor oncology with cellular therapy. And those are particularly surrounding questions that became topics for discussion in our session about the importance of lymphodepletion, about the importance of identifying ways to get the CAR T cells to traffic appropriately to tumors, as well as thinking about modifications to the CAR T cells that can help them be more both productive and persistent and have better functionality. And so I think from my perspective, I feel like I'm kind of the history here, but it's been incredibly empowering to hear that we're actually seeing, particularly with the story of Claudin-6, with the FSH ovarian, and in the GI oncology space as well, that we're actually seeing meaningful and truly, I think, remarkable steps forward where we're actually starting to see hints of true important disease activity. And so it was a great session, and I think a lot of discussion to try to figure out what are all the bits and pieces and the lessons that we can all learn from each other in terms of why does Claudin-6 work so well? Is it a component of adding the vaccine? Is it how do we use small molecule inhibitors? And so a lot of great back and forth and I think discussions that hopefully will be relevant for the entire field, even though we're all very kind of honed in on our own diseases.
I think there were like two commonalities. One is that you're both taking care of rare diseases, and people come from far away for these trials, and that's one of the questions that was also discussed. I'm going to talk about a little bit more is how do we recruit patients, and obviously, your patients, tend to be young, unfortunately, and they are usually treated in centers that have expertise, whether they're in the U.S. or in Europe. The other thing that I think that's also a couple of things. One is that you really have very restricted expression compared to things that we see in the GI, at least in the GI space. As a GI, when we're talking about HER2, which also is obviously in breast, but or EGFR, which you spoke about, which is also in breast, which is also throughout the GI tract and your skin, or even mesothelin, where we've seen these toxicities. The other thing I think that's really interesting is the use of adjuvants. And because, at least in what I do, what really has been the theme has been lack of efficacy. We certainly have seen toxicity, but there's been lack of efficacy. And even though we do have, as I mentioned, heroes, we have people who have responses, even perhaps the best data that's been presented, which is in Claudin 18.2, is probably furthest along in the GI space. If you look at it, the responses, most patients progress in progression is measured in months and not in years. So it's very different than hematologic. And yours seem to have much more, persistence. And this is what Dr. Specht was saying, whether it's related to something that's just different in the antigens, it's different in the constructs, or it's different in the adjuvants. Do you have any thoughts on any or all of those? Don't everyone jump in. And so
Dr. Alsdorf can comment on this. I think this idea of being able to somehow boost the response, and whether that's because you have a novel CAR construction. I spoke a little bit about work that's being done to look at a switchable CAR, where you can add a switch that essentially turns on and recognizes the antigen and boosts the response.
Are you with the switchable CAR, which I thought was really interesting? This is a caliber,
Yes.
Are they reinfused, or do these sort of CARs persist waiting for the adapter molecule? And because persistence has always been a theme in what we're talking about, so even if you put another adapter on for a different target, if the cells aren't there, or do you just, and then are you just kind of putting in these cells waiting for the adapter molecule?
Yeah, that's kind of the idea is that there's more of a universal CAR construct, and then you give the switch intravenously with the goal of then engaging and having activity of the CAR T cell, the cytotoxic activity. And with this technology, as it's proposed and has been shown, at least in some early data with CD19, the idea is that you can continue just after one CAR T cell infusion to generate activity by repeatedly dosing or pulsing the switch molecule. So there's potentially a lot of, it's a creative solution to one of the problems. But I guess, and going back to Dr. Alsdorf, I think this idea of combining a highly potent vaccine that is very safe is a very elegant way of thinking about how you achieve that same response with regard to improving efficacy.
But back to what I was saying, the problem is that you have to say that the cells are still there. And that's been one of our big problems. And so you can add your adapter, the switch. If the cells aren't there, they just aren't, there. There was an earlier discussion today about the need for biopsies and how important it is to get tissue to see, both for successes and for failures. And one of the main reasons for failure, at least in the GI space, has been lack of, persistence. Now, how do you do that? Dr. Specht talked about having multiple constructs to try to, the same idea about an adjuvant. Maybe what you're doing, it's easy, I can think, to design a trial with the lorlatinib because it's such an easy kind of on-off sort of thing. I think the vaccines are a little bit harder. How do you design that trial to see what the contribution and components of the vaccine are? What are you planning on doing with that?
Yeah, so the vaccines so first off, this was really an innovative trial because it was the very first approach where cellular therapy was combined with an mRNA vaccine. And so the first takeaway was we've seen so far is that this can be safely combined. And what is really interesting that we have some exceptional responder patients who really received the vaccine for more than 2 years. And then by protocol, it has been stopped. So we see the tolerability is there, but I think we still have huge challenges ahead. Because remember, this is a basket trial, many different tumor types, ovarian cancer, germ cell tumors have very different tumor biology, also some rare sarcomas in there, some GI cancers actually also might have CLDN6 like gastric cancer. So I think we're really now starting this new field of boosting cellular therapy with, combinational approaches. And luckily, the sponsor has now also investigated together with us a second-gen vaccine that is modified. So it is more active, provides a bigger boost, so to speak. And we're just now in those findings there, and we see some encouraging signals, but I think it's a long way to go. But what I pointed out in the presentation, there are some really exceptional cases where you only apply a low dose of CAR T cells, like only 10 million flat dose of cells, which is actually in that setting a rather low dose. But then that specific patient, if you look at the measurements, had a factor 1,000-fold expansion of the cells. So I think there are some really patients who respond. But the challenge for us lying ahead is identifying, actually pre-treatment, which patients are really going to respond really well to the combination of low-dose CAR T cells plus the vaccine, which patients do not require the vaccine, maybe even some of those patients are present in our trials, and which patients might require a higher dose of CAR T cells plus a certain dose of vaccine. And I think this is really the challenge, the heterogeneity of our patients and the diseases.
In general, while for infectious diseases, vaccines have been transformational, cancer vaccines so far have not necessarily worked that well. And particular where they haven't worked is in patients with established large solid tumors. But the hints have been mostly, and this was also part of a discussion that, including one of them from that same company, looking at pancreatic cancer, is in the setting of minimal residual disease. And so do you think that there's any way, one question is, do you think there's any way to do a study looking at basically, contribution of components? So in other words, maybe this is different somehow, and maybe either it's different because of the disease, which is an unusual disease, or because of your vaccine. Is that, would you ever see giving your second generation vaccine alone to try to see, once again, how much effect does it have on its own? And then the other question would be, are you planning on doing a trial where you actually look at, with and without vaccine?
Yeah, thanks for the great question. So really, I would consider actually, this is a long shot, but really going into the early disease space, because in specifically the germ cell tumors, we might have the opportunity in the stage 1 patients, which are the most common patients. If you have patients with non-seminoma and high risk, there's a big discussion by the experts going on, which patients should receive adjuvant chemotherapy and which ones not. And there are some people advising always active surveillance. So maybe there would be a place for such a vaccine. Of course, this would be done in a well-controlled clinical trial, but really in that patient without a lot of immunosuppression, without previous chemotherapy, I would think that such a second-gen vaccine might induce these endogenous responses. But I think right now with the trial combining vaccine with CAR T cells, we're really looking to boost the CAR T cells. And so I do not think right now that we have the data that suggests that there is a mono activity of just the vaccine, but I think we need to follow up more on some of our exceptional responder patients because we had some data suggesting that there might be some phenomena like epitope spreading, like we have some T cell receptor rearrangements being then present that suggest that maybe also by the activity of the CAR T cells, there is this activation of the endogenous immune system. We need to figure this out more. Yeah. But this is really exciting times that we see these patients that have long-term responses. And we need to figure out the perfect place of the vaccine.
Once again, having responses allows you to kind of ask these questions. And your patients, particularly by the time they go on your trials, have been so heavily pretreated, almost more than any other solid tumor. Yeah. Another question, this is because I don't know the neuroblastoma, is that field. Is that, are people looking at other ALK inhibitors like lorlatinib just as single agent? I think you had mentioned that, or just as an adjuvant to the CAR T?
No, so actually ALK inhibitors have sort of found their way into mainstay of upfront high-risk neuroblastoma therapy. So the Children's Oncology Group trials in their most recent trial that completed accrual, those patients with identified ALK aberrations were actually non-randomly assigned to a separate arm of the study to receive ALK inhibitor in addition to kind of the backbone of their therapy.
So then that goes to my next question, which is that you're using it to boost expression in the short term. Is that if there are patients who are on ALK inhibitors early on, would you expect as a resistance mechanism perhaps downregulation of expression, or would that make it, so I'm thinking about sequencing and timing. Do you think that would make a difference? Because it sounds like your therapy has the potential to be much more durable than a tyrosine kinase inhibitor. It may be bringing that up front. And so you know the field much better than I do. Yeah. But that's one of the resistance mechanisms that we see in single transduction inhibitors is downregulation basically of, whatever it is you're treating.
Yeah, I mean, I think many of the patients that will be eligible for the trial, and this speaks to, I think, the sequencing of when we investigate these early phase therapies, will be very heavily pretreated and have, relapsed or refractory disease. And so the patients who have had ALK aberrations identified, they would have had as sort of part of standard of care lorlatinib exposure, or that's the currently used ALK inhibitor. But there's also a large fragment of the neuroblastoma patients who have expressed the wild type receptor, and those patients wouldn't ordinarily, at least in the current kind of protocol design, have received lorlatinib. And then I think it depends. Are you using it primarily for upregulation of the ALK receptor, which that will be applicable for a large percentage of the patients? And then there's others where we hope that it'll have synergistic effect, both by virtue of ALK inhibition on the receptor, but also increase the ALK expression.
Dr. Specht, one thing that we did talk about, and I think you talked a little bit at the end, was also EGFR. Mm-hmm. And I don't know if you wanted to just have a couple words just about the upcoming, EGFR trials. I mean, it's something that I've worked with the EGFR space since the early 2000s with antibodies, but I think as a target and also perhaps as something that's both scary and also, as scary as well as sort of exciting about the idea about using that as a target, particularly in breast cancer.
Yeah, so not to date myself, but when bevacizumab was being used widely in triple-negative breast cancer, we actually had a investigator-initiated trial at our institution where we combined patients with triple-negative breast cancer who often have high levels of EGFR expression. We did a trial where they got chemotherapy and bevacizumab as an induction phase, and then we did a maintenance phase actually with erlotinib and bevacizumab. And there were actually a number of patients who were able to have a chemotherapy-free interval. Of course, the field has moved on and changed, but it makes me feel it's exciting to see that this target comes back. Mm-hmm. And specific to the upcoming study, which is with A2 Bio, they're looking at their logic-gated CAR T cell construct. And this is actually their first allogeneic agent. So it'll be for patients who are HLA-A02 haplotype, but for whom their tumor has lost heterozygosity and has EGFR expression. So I think that there's early data to suggest that this idea of the logic gating is allowing for higher cell doses to be administered with reasonable safety for targets that previously have been plagued with a lot of toxicity like CEA. And so I think there's kind of a lot of interest with this idea that there's some safety established in terms of being able to utilize other targets that are more heterogeneous and not so perfect in terms of antigen expression as in Claudin-6. So we're really excited to see this new trial come up online as a basket study. It'll include individuals with lots of different disease types where EGFR is overexpressed. But, and again, the idea of an off-the-shelf allogeneic CAR that doesn't require the timing that it takes for lymphodepletion is also potentially appealing and might open the space to a larger group of patients. So we're excited to see this, but like everything, it's slow steps, but really exciting to see some of the, I think, unequivocal successes that we're starting to see in the solid tumor space.
So in some ways, we're almost the inverse, where you have rare tumors and few patients. Once again, they come to you, but you have almost universally expressed targets. For us, we have actually the other problem, which is trying to identify patients who match these, whether it's a TCR where you're matching the KRAS specific mutation together with the HLA, or for this where you're matching, not so much because the target's relatively overexpressed, but you also HLA, and then loss of that HLA becomes difficult. And I'm a clinical trialist, and the idea is, how do you screen large numbers of patients without your basically your clinical staff exploding into flames, because you really do get screening burnout. And we had some brief discussions, but I think it's really important is how can we work together, both across companies, and also, now more and more patients are getting next generation sequencing. So we're at least finding the mutations. I would say that almost, especially since you have the rare things like NTRK fusions and things like that, which I'm still waiting to see one in what I do, at least in the United States, insurance is paying for that, and the NGS companies, if insurance is not paying for it, are usually working with you. So that's not the barrier that it was even just a few years ago. But the question is, how do we get all the players in the game to work together? Because trying to get this set up so that we don't screen 100 patients to get one, instead that the patients like you have, what we want is actually what you have to a certain extent, not really young patients, but patients who we know colon cancer is becoming a younger disease, though not quite that young. But so that we can have the patients in some ways come to us already identified. I think if you want to know one of the things that will really help move the field along, I mean, obviously better constructs, better drugs are always better, but also this ability to be able to identify patients and also to send patients, if we have a trial and that we're busy looking and we find something for somewhere else, the ability, where there's a trial in Seattle, or whether there's a trial wherever, or there's a trial across town, being able to send the patients to those molecularly matched trials, I think will be really important in the future.
Yeah, I really agree that it's pointed out a very specific issue with clinical trials. They become more demanding, more complex. We have rare diseases or we have common diseases, but you look at a really tiny subpopulation. So I really fully agree. We need more cooperation. We need to find, innovative solutions to this. Actually, what I've come across is some, really nicely designed clinical trials where they allow, different from your typical phase 1 perspective, that you get to refer very late, the patient has exhausted all standard treatment options, really difficult setting, the patient is, in a dire situation, is really, at very high risk, also emotionally for the patients, it's really extremely stressful and not the perfect setting for discussing first-in-human trials in the first place. But there are some trials that really allow, at the beginning of first-line treatment for metastatic disease, do your HLA typing, do your biomarker testing. Even there are some trials that would allow lymphocyte apheresis for cellular therapies. There are these trials out there, and I think we can learn from these trials. And I think we need to, as a field and community, move forward to find better solutions, because I fully agree that your staff can have a burnout from having all these pre-screening failures.
No, I think that's really interesting. At least in the US, one thing is that the FDA, for incurable disease in colon, which is a lot of what I do, is allowing innovative trials in second line. We know that patients with second line have run second line trials. Median progression-free survival is measured in single-digit months, depending on the study, and so there's no problem. I think the other thing that you mentioned, I think that was also really important, is if you are going to be doing apheresis as opposed to an off-the-shelf, is that your patients, both of your patients are really heavily pretreated. It's really nice to get those cells before they've had multiple lines of therapy. And in fact, Dr. Specht brought up earlier about the idea of possibly having the stakeholders put together, a white paper. No one no one has volunteered yet necessarily to write or to herd the cats in order to do it. But I think this is actually where, because iwCAR-T has done white papers that have been really influential, and this might be something in the solid tumor space that would, I think would actually move the field forward and would be to a certain extent solid tumor histology agnostic and also necessarily company agnostic. Okay. Yeah. Any other finishing thoughts or final thoughts that anyone has?
Completely agree, and I think that it's becoming more and more important not only to have the genomic data, but to collect data like HLA, as we think and we see more and more therapies, whether they're TCRs or CARs and others that require that restriction. So the ability to get the word out, so to speak, to our colleagues on the importance of those testing information to really help patients down the road.
Okay. Well, thank you very much for your attention.
Thank you.